Thank you, Mr. Chairman, and good morning, ladies and gentlemen. It's my great honor to talk about this current management on the BD-IPMN. The no COI, after explaining the recently changing the concept of IPMN, I will address the consideration point in decision-making for surgery or surveillance and the proposed customized approach for surgery. According to the recent data, the pancreatic lesions were incidentally detected in 0.47% of the population. Of these, the cystic neoplasm occupied 74%. With the improved resolution of imaging and accessibility increasing in the medical healthcare, we could experience more and more patients with the pancreatic region. So this is a website graph shows the report from the United States. You can see the 14-fold increase in the detection of pancreatic neoplasm compared to the 20 years ago. According to the right side of our study, the prevalence of the cystic region is 2.2% of normal population, and IPMN is the most prevalent cystic neoplasm. In the past international conference, most of the legendary pancreatic surgeons insist that all IPMN, including BD-IPMN, must be resected due to the malignant potential. However, there have been dramatic changes in the management of IPMN. So currently, most of the clinical guidelines recommend the observation, not surgery, for most of the BD-IPMN. This is a report from the Memorial Sloan Kettering Cancer Center. You can find that the increasing number of patients with a cyst. However, compared to the previous stage, rest stage show the decreasing the tumor size from the 4 centimeter to the 1.6 centimeter. So situation of BD-IPMN is very different compared to 10 or 20 years ago. So in this confusing situation, there have been many guidelines released from the pathological diagnosis to the treatment algorithm. Already, Professor Wolfgang beautifully summarized the difference of each guideline, dealing with some key point and gray zone. Of several guidelines, most widely used one is the IAP guideline and the European guideline. Compared to the previous version, red one is a new proposal in revised version. The size criterion on the mural nodule over 5 mm for high-risk stigmata, and the rapid growing cyst and elevated tumor marker in the worrisome feature. IAP recommends surgery for high-risk stigmata, and in those with the worrisome feature negative, surveillance is recommended according to this protocol. In case with the worrisome feature positive, surgery or surveillance must be selected by the physician and surgeon. However, just the listing of this long list of the worrisome feature is not practical to decide the treatment. So we need more information to decide the surgery or surveillance for the patient with the BD-IPMN. In selecting the treatment, surveillance, or resection, we must consider the many factors such as the disease factor, the mainly natural history and malignant potential, and the host factor, including the operative risk and life expectancy. Thereby, there is no the universal rule to decide the treatment. From now, I will briefly summarize the important factor in decision-making for the optimal treatment on IPMN. This is the early report on natural history on IPMN released by a French group. The 5 years, the cumulative malignancy risk is 15% of BD-IPMN, much lower than the main duct IPMN, over 60%. So they insist that the non-operative surveillance was justified. The malignancy risk is 2 or 3% according to this study. The recent study from Italian Verona group showed the BD-IPM is much more indolent than the previous report. 5 years disease-specific survival, there was 96%, even in the patient with worsened feature positive. The risk of IPM-related death is tenfold greater for the patient with a high-risk stigmata. So they insist that the clinical course of the patient with worsened feature positive seems to be indolent. So the non-operative management may be appropriate, especially for old age patient, considering the high mortality induced by the non-IPMN related disease, such as the cardiac disease. However, we must consider the cumulative increasing risk of malignancy during the surveillance. As you can see the left side graph, that there is increasing risk of malignancy, especially with the worsened feature positive, according to the recent meta-analysis. A clinician must bear in mind that IPMN is a precursor of pancreatic cancer, most lethal cancer in the world, according to the systematic review from the American Gastroenterology Association. The 5-year survival rate of the malignant IPMN is 67% and invasiveness at 40%, which is lower than that of the gastric or colon cancer. So the prevention of the PDAC must be the primary goal in the management of the high-risk IPMN. Unfortunately, we have the very limited evidence, especially on the long-term natural history. So I performed the extensive review on whole IPMN suspected cases and over 10,000 in our hospital. Many of data is just dealing with the patient in department surgery, so that they has some selection bias in most of the cases, but we collected all patients in our hospital, including the physician, the dealing with patient, or the surgeons. After selecting the cases with the typical radiological finding, we measured the size and morphological change of BD and mixed type IPMN. The median follow-up time is over 5 years, and the annual growing rate is 0.6 millimeter. Out of eligible patients, 172 patients presented with a worsened feature, like the second cyst wall is the most common, followed by the cyst size increasing and PDAC dilatation. And 20 patients, the right side, showed the increasing number of the worsened feature during the surveillance. The overall 14% of patients showed a newly developed worsened feature during the surveillance. Annually, 3% patient has the worsened feature positive from negative. During follow-up period, the 46 patients, about 3.4% received the operation. And 13 patients, 1%, turned out to be the malignant in surgical biopsy. During surveillance, the biopsy proved malignancy in 1%, and the sum of the right side, the aggravated patient out of 15, and it would be the true malignant IPMN during the surveillance. So true malignancy conversion rate of the BD IPMN must be 1 or 2% during the 5 years, which means the annual malignancy risk would be the 0.2 or the 0.4%. So optimal surveillance is a useful and safe strategy for BD IPMN currently, considering the minimal risk of the malignancy conversion. But the early detection of malignant transformation is very important. During the surveillance, there are some outlier, extreme outlier with a rapid growing. And this rapid growing cyst has a higher risk of the malignancy transformation. This patient must be the candidate for the close surveillance or early surgery, especially for younger patients or the family history. During the surveillance, you must keep in mind that increase in cyst size is correlated with the increasing risk of other malignant feature, worsened feature, such as main PDAC dilatation and mural nodal positive. The risk especially increased, becomes higher in the cyst over 2 centimeters. So we calculate the optimal surveillance interval. So we calculate the optimal surveillance interval, the constant the cyst growing rate and doubling time and risk of the outlier based on the long-term natural history. So this new revised IAP surveillance guideline is based on the large-scale natural history study, not just the expert opinion of the previous guideline or other guideline. Cyst less than the 2 centimeter, a 2-year interval follow-up is enough. However, initially the 6 months short-term screening is needed 1 time or 2 times according to the cyst size to pick up the rapid growing outlier. Cysts between the 2 or 3 centimeter, cyst growth rate is faster compared to the small cysts, and the more worrisome features are observed during the follow-up period. So the biannual follow-up is recommended for the first years, and then 1 year's interval follow-up is recommended. The photocyst over 3 centimeters, 6 months interval follow-up is recommended. According to patient age, you can rank to the 1 year. Anyway, and the patient with a risk factor such as a family history or other worrisome features in the patient with over 3 centimeters, in young, especially in young patient, surgery is strongly recommended by IAP guideline. Let's move to the final topic. How can you select the optimal candidate for surgery for IPMN if you choose the surveillance? I think the selection of candidate for surgery is very important to be balanced with the surgical risk and the cancer risk to prevent the pancreatic cancer. IAPN recently released the European guideline are very similar. There is a loss of the worrisome feature the right side. Practically some of cases positive worrisome feature are difficult to make a decision in the selection between the observation and surgery. Let me show some representative cases. All of patients has the similar age, around 75 years old. The first case, the cyst size of only the 16 millimeter, p-duct dilatation is 4 millimeter, but the mural load positive and slightly elevated tumor marker. Could you select the observation or surgery in this patient? The second case is the 40 millimeter BD IPMN with no other worrisome feature. Third one is a 42 cyst size, 9 millimeter p-duct dilatation, and no mural nodule with a normal tumor marker. Each patient has the different worrisome features. How can you select the surgery or observation in this patient? It is very complicated. So anyways, as you can see here, the hazard ratio of each worrisome feature is very different. For the mural nodule, positivity has a 5 times higher malignancy predictor compared to the cyst size over the 3 centimeter. So this is a summary of the hazard ratio with each malignancy predicting factor. Also, we must consider the additive effect of the several risk factors. For example, those with the 3 risk factors had a higher malignancy potential than those patients with only the 1 malignancy predicting factor. They have only 40% diagnosis accuracy. So we need the quantitative prediction of malignancy in IPMN. Already previous speaker showed that biological marker could be used. However, it needs much money and external validation in the future. Anyways, such a system to calculate the malignancy is very useful for personalized approach for the patient with BD-IPMN. To make a nomogram predicting malignancy risk in IPMN, I performed the world's largest scaled collaboration study between Korea and Japan. We could collect the 2,500 cases of branch or mixed type IPMN. Through the internal and external validation, we could make the nomogram predicting malignancy. So we developed a user-friendly web-based this nomogram that is freely available. After external validation, we could find that this nomogram works very well with the AUC over 1.8. If you input the patient data in this website, including the age and tumor morphology, so you could easily measure the individual risk of malignancy and invasiveness in the patient with BD or mixed type IPMN. As you may know that the sensitivity and specificity has a negative correlation, as the previous speaker, Dr. Wolfgang, beautifully summarized that. If we check the diagnostic value of the nomogram according to the threshold, the probability of the malignancy, the balanced accuracy is the maximum at 0.37. But the diagnostic accuracy is very similar between the 30 to 40%. So you can strongly recommend the surgery if the probability of the malignancy is over 30 or 40%, considering the patient condition. You can individually lower the threshold for surgery if the patient is younger. So as according to your policy, you can higher or lower the threshold to select the candidate for surgery using this nomogram. Anyway, our nomogram was based on the Korean and Japan cohort. So external validation using the different Western and other Eastern cohort must be needed to be globally used. From the last year, I have collaborated with several renowned pancreatic cancer centers all over the world. The 2 large European centers, Karolinska and AMC, and the 2 American centers, including Hopkins, the 2 China and 2 Taiwan major pancreatic cancer centers joined at this global collaboration to confirm the effect of the nomogram in clinical uses. The Western cohort show that the old age, more female patient compared to the Eastern side, the less the instance of the tumor region, and then the higher, smaller size, but the higher rate of the mural nodule. As you can see here, the AUC is very similar to our previous report from the Korean and Japan cohort. Western cohort showed the higher AUC than the new Eastern cohort. This data show that our nomogram could be used globally to predict the malignancy in BD or mixed type IPMN. Now let's move to the previous cases. When you applied our nomogram, first case showed a 47% of malignancy risk with a 21% of invasiveness. After surgical resection, the final biopsy, the pathological report showed that the invasive IPMN with T1 and 0. The second case showed only the 17% of malignancy risk. Anyway, the surgical pathology is just low-grade dysplasia. So we can just select the observation in the patient with only large cyst over 3 or the 4 centimeter without the worrisome feature using this nomogram. The final case shows a 44% malignancy risk. In this patient, final pathology diagnosis, T2N1 invasive cancer. Definitely need the urgent treatment after surgical resection also. Anyway, beside the nomogram, the several nomograms are available in the world, showing the similar diagnostic accuracy. First one is very simple, dealing with only the mural nodule, cyst size, and weight loss, with the lowest diagnostic value. The Japanese one need the cytology, but the routine cytology examination is not recommended because it is an invasive procedure, and then also the risk of the tumor spillage during the EUS cystic aspiration. The currently American consortium and our nomogram are mostly useful to predict the malignancy in BD-IPMN. Both of them use the mural nodule and tumor size, age, but American system use the symptoms, very non-specific, but no PDOC size they use. They use different nomogram for mixed type IPMN. When I did the external validation to compare the diagnostic accuracy of the two nomogram using the Eastern and Western cohort, not used in the model development, we could find that the AUC of American consortium is 0.63, a little bit lower than ours, 0.77, which show that our nomogram could be universally used for malignancy prediction, BD, or the mixed type IPMN. Now let me summarize my talks. The detection of small IPMN has been increasing. Most of BD IPMN is dormant, and the malignancy conversion rate is just 0.2 or 0.4%, and large cyst over the 3 centimeter or growing BD IPMN must be carefully monitored due to the increasing risk of malignancy. And tailored approach is needed to selection the cases of the surgery or surveillance, considering the malignancy potential and patient factor. And nomogram could be a valuable tool in counseling and decision-making for selecting the treatment method as a customized approach for IPMN. This is my final slide for treatment algorithm of IPMN. If the patient have the symptoms or high-risk stigmata, such as the red-listed factor, the surgical resection is strongly recommended. If there is no worrisome feature, the surveillance is recommended according to the cyst size, which was released in IAP, new released guideline protocol. If the patient showed worrisome features, nomogram can be useful method to select the surgical candidate. If the malignancy risk is estimated over 30 to 40%, you could strongly recommend the surgery rather than the surveillance. Using this concept, we can reduce the unnecessary operation and select the optimal candidate for surgery to prevent the pancreatic cancer. I appreciate all pancreatic surgeons who involved in this study, and thank you for your kind attention. Next year we will hold the 7th Asian Pacific HVP Association meeting at Seoul, Korea. As a scientific committee chair, I would like to invite all of the pancreatic surgeons in the world and the sharing our friendship and the current knowledge. Thank you for your attention.
Thank you. Thank you, Dr. Jang, for an outstanding talk. I have one or two questions I'd like to ask you. We have four nomograms around the world.
Actually speaking, the 5 is the released in the world, but the one nomogram, they did not use the internal, even the internal validation. So the 4 is available.
My question is, each of those nomograms are based on a data set.
Yeah.
Is there any move to look at combining the data sets?
Yeah. That is a very important question. So as I said, in our nomogram, we include the several countries and several data from the America, Europe, and Asia. Asia is several countries, including Korea and Japan, and China and Taiwan. So the next version is I'd like to improve the diagnostic performance of the nomogram, so adapting some new point. I think the current guideline is based on the previous imaging technique. So compared to the past imaging technique, we have the more delegated, high resolution imaging techniques. So we will combine the new data, we will improve the nomogram to predict the malignancy in the future.
Second question, Dr. Jang, is are you looking for more centers to join with you?
Of course.
Yeah, okay. Yeah. Okay, and third question is, given the differences between East and West that you showed, do you think the nomogram will not be universal but regional?
So anyway, that is the key question to external validate my nomogram to the Western people. So surprisingly, I found that diagnostic accuracy is very high compared to even to the Eastern cohort. So, however, many of the Western countries do not check the tumor marker currently. So when we check the tumor marker with combined the radiological imaging, I think the diagnostic performance maybe is similar or better than the previous one.
All right. One question.
Radenkovic, Belgrade, Serbia. Thank you very much for your nice presentation. I would like to ask a question. Due to different cultural things between Asia and Europe, we'll see in Professor Wolgan's also presentation. We are talking about the personalized medicine, but we in Europe are now giving more advantage to the talk with the patients and for the personal wish of our patients. Because we see in your presentation that you have three similar cases and we expect it will not be T2 tumor and that one had a very advanced tumor. So do you use it, do you talk with your patient in Asia and whether it's your policy according to this issue? Thank you.
Yes, that is very important. So even for the pancreatic cancer, I think the surgeon from the Western and Eastern has a slightly different viewpoint. Also, some of the surgeons working at a different hospital in the same region has a different surgical policy. So I think however, comparing the Eastern and Western cohort, I think some of the populations is different, including the age, sex, and the selection criteria. However, combining all data, I showed blindly I performed 100 times to external validation to rule out the selection bias. But as you can see here, the data between the Eastern and Western using the cohort, I think the nomogram is working very well, even the Western patient.
Thank you.
Okay, thank you very much.